It is good to see you all. We're going to jump right in. So I want to say hello and welcome to Persyst Grand Rounds. We are an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. I'm Marie Terrell, Director of Product Management with Persyst, here to introduce our speaker and topic for today's Persyst Grand Rounds. Next slide, please. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their expertise and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. And you can visit www.persyst.com/grandrounds to keep up to date. Next slide. So the opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity. Speakers are not required to include Persyst, its software, products, or services. This content was not prepared or edited by Persyst, and Persyst is not providing any form of compensation. And last slide. Okay, so there will be time for questions after the talk, and you can write your questions in the Q&A area. There's a button at the bottom of your screen. We are also recording this lecture, and it will be made available afterwards. So today, we welcome Dr. Jennifer Keene. Dr. Keene completed her medical degree at Cleveland Clinic after receiving an MBA in Technology Innovation and a master's in Neural Engineering from Case Western Reserve University. She completed her Pediatric and Neurology residencies at Seattle Children's and her Neonatal Neurology fellowship at Washington University in St. Louis. She is board certified in Child Neurology. She is currently an assistant professor in the Division of Pediatric Neurology at the University of Utah Medical School. Dr. Keene's interests lie in continuing to improve neuroprotective care and recovery for neonates and children in the intensive care unit. She specializes in the care of children throughout early life, including fetal counseling, care of neonates with seizures, strokes, brain malformations, brain bleeds, and other neurologic issues, and care of children in the Pediatric ICU. She focuses on helping children and families rehabilitate and reach their potential after early life brain injuries. Her research focuses on improving understanding of early life brain monitoring and improving outcomes after NeuroICU care. Today, Dr. Keene is speaking on quantitative EEG in the neonatal ICU, current use and new horizons. The learning objectives will be to review the use of quantitative EEG trends in the neonatal ICU setting, to discuss emerging evidence for the use of AI-based seizure detection in the neonatal ICU, and to discuss the use of quantitative EEG measures in neonatal ICU prognosis. And so, Dr. Keene, thank you so much for being here with us today, and it's all you.
Well, thank you so much for having me. This is one of my favorite topics in the world to chat about, so I'm looking forward to it. So let's dive in. In terms of disclosures, I have no commercial disclosures. We're not specifically going to be talking about treatments of neonatal seizures, but if you ask me a question about it, I will probably talk about something that's off-label because nearly everything to treat neonatal seizures are. And we are going to be talking just a little bit about some unpublished data because I literally pulled an interim data analysis on a pertinent project this morning to be able to share with you. So, learning objectives. There have been some other wonderful talks in this series that have gone over a number of quantitative EEG trends in detail. So we're going to focus a little bit on reviewing some of the quantitative trends that are specifically used in the NICU. We're going to talk some about quantitative EEG for seizure detection and the fact that our new machine learning algorithms actually are looking pretty darn good. And then we're going to touch a little bit on quantitative EEG for background evaluation and some of the promising new quantification that supports prognosis, which is exciting to me. So to start with, looking at some of our favorite trends in the NICU, we're going to highlight 3 different categories of trends. We're going to talk about 2 amplitude-based trends, amplitude integrated EEG and suppression ratio. We're going to talk about 2 frequency-based trends, fast Fourier transform spectrograms and asymmetry spectrograms. And we're going to touch a little bit on raw EEG machine learning, the lovely black box there. We're mostly going to touch on that when we get to the research and new data section of this talk. So it turns out that the NICU is probably the place that quantitative EEG is most widely and frequently used. And that's because NICUs around the world use amplitude integrated EEG. And they often use it as a standalone rather than in combination with many other trends, which is what we more typically see in the PICU. So when I say amplitude integrated EEG, what does that usually mean in the NICU setting? Rather than having the 16 or so channels that we typically think of for a full neonatal montage EEG, you have 1 to 2 channels of EEG, and you take that data, you rectify and compress it, and that's what's usually shown at bedside. And is typically interpreted at bedside by the neonatal nurses, neonatal nurse practitioners, and neonatal providers rather than by electrophysiologists in most settings. So when I say rectified and compressed, what do I mean? So it's rectified, all the negatives are made positive. And then for every several seconds, the maximum and minimum of that rectified voltage is found. And then the absolute value of that minimum and maximum is plotted next to each other. And that lets us look at trends over time for a baby. And it's actually a beautiful way to really look at that background. So for a kiddo who has a continuous normal voltage, you have this narrower band. You can see some waxing and waning with sleep. Versus a discontinuous normal voltage is going to be this wider band. Burst suppression with that really low baseline looks like this, and then continuous low voltage. And of course, most of the time when we're using any sort of EEG in the NICU, the thing that is of most interest is seizures. So what does a seizure look on EEG? Well, it classically looks like this, quote, flame-shaped change where you have a sudden increase in both the lower and upper margins on at least one side, noting that babies tend to have more focal seizures. So you're more likely to get one side versus both demonstrating your seizure compared to older kiddos or adults. Now, what does this look like in a quantitative EEG program that many of us may be familiar with, or as part of a multi-panel trend? So this is an example of how we essentially create an EEG. If we're looking at this second here, this relatively discontinuous second, that's where we're going to get that lower margin. And then if we look at the burst, that's going to provide us with this upper margin. So we're going to have this relatively broader area on our AEG, as opposed to a screen a little bit later, where we're in this more continuous period, they all look relatively similar. So you're going to have a narrower band of lower and upper margin. And then if we have a seizure, a very large seizure that's involving both sides of the brain, you get that flame shape. And in this case, you can see it on both the left and the right hemisphere. Now, the other amplitude trend that we sometimes rely on in the NICU is looking at the suppression ratio. And that trend is exactly what it sounds like. It's the percentage of time the EEG is suppressed below a set threshold. The default is often 3 to 5 microvolts. So in this example, it's approximately 62% suppressed on this page, and it's displayed as a running average over time with, again, your left and your right hemisphere visible. And one of the things that's useful in the NICU is that threshold is settable. And so sometimes we'll actually change that a little bit and say, well, and use it to trend discontinuity rather than burst suppression. Now let's talk a little bit about frequency-based trends. And I am going to do just a little bit of background on how we get them. Don't worry, the math won't last too long. So when we think about a fast Fourier transform, what we know is that our EEG signal that we all know and love is composed of a mix of waves across frequency, and a fast Fourier transform just decomposes that signal into its frequency contributions. And then the area under the amplitude curve for those frequency contributions is the power. And so if we look at how we build this trend, if we take a monomorphic signal that's all at one frequency, we look at the area under that frequency, we get power at, in this case, approximately 8 hertz. And then we transform that into color. And so that gives us the power at a specific frequency over time. And then if we then look at our combination, which is what our real EEG signal is, we get our power for each one, and we can see each of those power bands at the various frequencies over time. And we start transition that into what it looks like in the real world, where we have very complex signals that we decompose, find the power of, and transform into color with our power over time. And we get these lovely information dense, but very visibly easy to interpret trends that tell us all about the power over time for any given kiddo, which is really useful for being able to see easily, are we having big changes in our frequency distribution? Are we suddenly losing our high frequency powers? Are we seeing a sudden change that we wouldn't expect to see over time? Maybe it's medications, maybe it's something that's more concerning that we need to go investigate, get a head ultrasound now, which is often our answer in the NICU. And last, the asymmetry spectrogram is again what it sounds like. If we have perfect balance, or this is across our frequency panel from 1 hertz to 18 hertz over time. And if we have perfect balance between our left and right hemispheres, it's going to look white. If at that particular power range, we have a lot more power on the left, it's going to be blue. So we've got, in this example, a lot more power on the left side at our low frequencies, and some more power on the right side at our higher frequencies. Now, it doesn't tell you anything about why you have that power differential, and maybe you already knew that one side had had a stroke or an ischemic injury of a different type and had lost its higher frequencies. But if you didn't expect to find this, something to look into. So now that we've talked a little bit about some of the trends that we use, let's dive into what most people care about, which is how do we find seizures? And before we dive into how do we find them, hopefully I'm mostly preaching to the choir when I say we probably should find them, and we should find them fast, and we should find them well. When we think about neonatal seizures, they're really common. Between 1 and 5 per 1,000 term neonates, and probably much more frequent in the preterm population, between 5 and 48%, depending on the study that you're looking at. And what we do know is that seizures are independently associated with brain injury, that high seizure burden is associated with mortality and poor neurodevelopmental outcomes, that early seizure recognition and treatment is associated with improved response to treatment and lower seizure burden, which makes sense. These are the things that we know and see in our older kids and in our adults. But because babies are sneaky, that was not necessarily as obvious until relatively recently. And in fact, this is from the updated ILE guidelines for recognizing seizures. And one thing you'll notice is that these updated guidelines require EEG to diagnose seizures in babies. And that's because babies are tricksy. When in a now classic study, when Malone et al. Asked 137 experienced NICU personnel to review videos of seizures and seizure mimics, the percentage that they were correct about whether or not the baby was actually having a seizure was 50%. Flip of a coin. And we know that many things that are commonly mistaken for seizures include jitteriness, sleep myoclonus, abnormal movements, either of an abnormal brain or secondary all the medications we give in the NICU, vital sign fluctuations, all commonly mistaken. And in fact, in another study, when we looked at what events were identified by nursing at bedside as seizures, 73% of them were not, in fact, seizures. On the flip side, pretty much every talk about neonatal seizures is contractually obligated to have a picture of an iceberg, because depending on what study you're looking at, something like 93% of neonatal seizures don't have a clinical correlate. So you really need an EEG to have any idea whether or not a baby is seizing and when they're seizing. So which baby should we be watching? And the answer is all the babies. Well, it's not actually all the babies, but for those of us who are reading neonatal EEGs or taking care of babies who might be having seizures, it certainly feels like all the babies. This is a list from the American Clinical Neurophysiology Society guidelines on which baby should have at least 24 hours of EEG. As you can see, it's a pretty broad representation of the babies who make their way to the NICU. These guidelines are from 2011. They're currently being updated, but the draft updated guidelines continue to support continuous EEG for many high-risk populations in the NICU. So we know that neonatal seizure diagnosis is important, but it's tricky when you need an EEG. There are a lot of babies at risk. So what makes it challenging to just monitor all the babies on EEG? Well, even though it seems like we should have a clear-cut criteria for what a neonatal seizure is, and we do, it's sudden, repetitive, evolving changes depending on which guideline body you're looking at. You may or may not use the 10-second guideline. Despite having these seemingly clear criteria, humans actually still have a very high level of disagreement. So two examples. One comes from the Neonatal 2 trial, which is a randomized controlled trial to compare the efficacy of Keppra and phenobarbital that I suspect many of you are familiar with. And during the protocol for this study, this was carried out at centers that all had a commitment to really high level, excellent care of neonates with seizures. These studies were being reviewed continuously by techs who were familiar with neonatal EEGs and were aided by an early version of Persyst neonatal seizure detection. There were on-site epileptologists, pediatric epileptologists who are familiar with neonatal seizures, who confirmed seizures identified by the technologists and made the decision to treat. And then there was two central epileptologists with expertise in neonatal EEG who read the EEGs blinded, and a third reader was used if there was a discrepancy. So given our seemingly clear-cut criteria, you would think you wouldn't need a third reader to break the tie very often. Not so much. 20% of the time, you had disagreement between your two expert neonatal EEG readers. And on top of that, 11% of the time, the research read did not confirm your local epileptologist's read, of which 5% were critical disagreements between the local read and the research read, with 3 that had untreated seizures not identified by local neurologists, and 2 with treatment with both drugs without a confirmed seizure between. And that's in pretty much your best case, highest monitoring situation. And it wasn't just that trial. It's not just that, they happened to pick less than ideal readers or something silly like that. We see this in many studies. A good example is from Stevenson et al. That looked at 4,000 hours of conventional neonatal EEG from 70 patients. And they looked at the agreement rate by an any overlap method between 2 expert neonatal EEG readers. And the answer was that they agreed approximately 78% of the time, with a mean false positive rate of 3.4 per day. And when we look at where we had that, we can see that this is each of these columns is the percent agreement for an individual baby with seizures. And we can see that for some babies, they had really obvious seizures. They agreed 100% of the time. And some babies, they agreed a much lower percentage of the time, 10 to 20%. And when they dug a little bit more into what contributed to that agreement, we could see that our percent agreement goes up substantially when we get to seizures that are greater than 30 to 50 seconds. And once they're very long seizures, our agreement rate hovers around that 90%. Now, neonatal seizures have one additional challenge in terms of seizure diagnosis, and that is that all these last two studies we were looking at were with conventional neonatal montage EEG. And in many cases, neonates are monitored just with amplitude integrated EEG. And when you have someone who is a real expert reader of amplitude integrated EEG, it works pretty darn well. If they think that a baby is seizing, there's about an 85% probability that would agree with a conventional EEG read that the baby is seizing. Not too shabby. However, there is a lot less controls on who is reading an amplitude integrated EEG rather than who, it's pretty much epileptologists who are reading conventional EEG. And so when you have someone who is inexperienced who's reading an amplitude integrated EEG, if they think the baby is seizing, there's something like a 35% chance that it's actually a seizure on conventional EEG. So a much wider and more challenging spectrum. Now, despite all of that data we just talked about how hard it is to diagnose neonatal seizures, humans perhaps don't recognize that in the moment. So this was a study that was 300 30-minute recordings of EEG experts that were going through and reading and just trying to classify the seizure, these 30-minute segments as to normal, ictal, non-ictal, and abnormal. And their agreement was fair to moderate. Cohen's kappa of 0.29 to 0.62 for these inter-reader pairs. Despite that pretty mediocre agreement, 5 of the 6 readers had a medium confidence that they were absolutely right on their gradings of greater than 99%. So it's challenging, but maybe doesn't always feel that way. So some of the challenges with EEG is that it really requires an expert knowledge to read. Even when we do have an expert, it's still challenging to consistently diagnose neonatal seizures. And it's expensive and resource intensive, particularly for full montage continuous EEG with tech review and epileptologist review. So I think one of the really exciting questions is whether improving quantitative EEG methods can help us address some of these challenges. And we have seen a lot of evolution in seizure detection algorithms over the last 20 years. We initially were doing a lot of work on feature-based identification of neonatal seizures. As we got into the 2010s, we were looking at combining features and using machine learning to optimize that seizure selection or the feature selection. And now we're getting to the point that we can do machine learning based on raw EEG signal. And there are multiple machine learning neonatal specific algorithms under development globally. And so when we think about that evolving area of expertise, one of the questions is, well, how well have these performed in the past? And so there was an absolutely beautiful multi-center randomized trial bedside implementation of a hybrid feature-based algorithm in Europe, the answer algorithm. And they managed to randomize 264 neonates. They used a gold standard of seizures that were identified by overlap of 2 experts that were at least 30 seconds long, so very clear-cut seizures. And with that, the algorithm identified 81.3% of the babies with seizures, with a specificity of 84% and a false detection rate by the clinical team of 37%. It identified 66% of the seizure hours, and there was no significant differences between the groups that did and did not have the algorithm to use at bedside in sensitivity, specificity, or false detection rate. So it was a beautiful study, but it was not as compelling to use this previous generation neonatal seizure detection as I think many in the community were hoping. Around the same time, the first generation Persyst seizure detection that was used with that Neonatal 2 trial we talked about earlier didn't publish the specific performance, but did publish a qualitative discussion of the use of this neonatal seizure detector. And this quote that I like is that all study neurologists found the automated neonatal seizure detection algorithm a useful tool for seizure detection, but many commented the algorithm demonstrated fairly high sensitivity, but the false positives were common. And it was not such that it could be related upon. And I think most telling, there was an instant messaging alert that was supposed to alert them if there was a seizure in order for review. And only 2 of the 9 neurologists kept it on. All the others turned it off because there was too many false positives, which I think echoes probably most of our clinical experience, that the previous and somewhat current generation of neonatal seizure detectors is okay. So my team's question, and this is where we're getting to that unpublished data that I'm sharing with y'all, is with our new generation seizure detectors using raw EEG, how are they doing? So we have a retrospective cohort of 173 term neonates who have neonatal encephalopathy. They were monitored for a median of 100 hours each. They all had a clinical pediatric neurophysiologist review at the time, and first seizure was reported in the record. And then we did a separate expert neonatal neurophysiologist research review and annotated all of seizures over 16,000 hours. We had N equals 56 or 32% of our cohort who had seizures. 97% of them were undergoing therapeutic hypothermia. A small group was identified too late to initiate therapeutic hypothermia, was still monitored on EEG. And we compared human expert seizure detection to 3 different algorithms. One is BABA Classic, that's what we called it anyways, which is a hybrid feature-based convolution neural network based from the BABA lab in Finland. So this is one of those previous generation algorithms. And then we compared it to 2 new algorithms. One is a neonatal specific machine learning raw EEG based research algorithm out of Australia. We have labeled as NSDA. And the last is Persyst 15, the neonatal specific machine learning raw EEG based, not research algorithm, commercially available algorithm that is FDA approved and now being released. So for each of these, it turns out that evaluating how well a neonatal seizure detector works is actually pretty complicated because there's lots of different ways that you can evaluate it. So we all can, and we should probably look at a number of different ways of evaluating a seizure detector. So our cohort has an expert read, a clinical read, and then for each algorithm, a seizure detection read. And on a per patient basis, we looked at per patient seizure detection, how many of the babies with seizures were correctly identified, and what was the time from the first seizure to the first time the algorithm picked it up. Are we talking that our algorithm figures it out in a minute or 2, or are we talking that eventually a few hours later, the algorithm picks up that this baby is seizing? And then on an event basis, a seizure event detection, that percent of agreement, and we used any overlap like the studies that I showed you earlier. And then importantly, looking at our false detections per day, since we know that's really important for whether or not your algorithm gets turned off. And so this is, we have not finished analysis of all of our patients. So I'm going to show you the ones that we do have as of this morning. So for BABA we have, and for NSDA, we've analyzed 95 of the 173. And on a per patient basis, the BABA algorithm, that previous generation algorithm, identified 98% of the babies who were seizing. It missed one. But every single one that did not have seizures had false detections. In terms of event-based, it identified 71% of the expert identified seizures. This is the interquartile range, 25 to 75th percentile. And in terms of false detections, 67 false detections in the babies with seizures and 86 false detections median in those without seizures per 24-hour period. And the time to identify a first seizure in those that did have seizures was pretty quick, 1 minute. Okay. For NSDA, our research algorithm out of Australia that is brought EEG based, this modern new generation algorithm, of those babies with seizures, it identified 94% correctly. There was 3 patients with seizures that were missed. It also had false detections on 93% of the babies without seizures. It only identified by any overlap 35% of the individual seizures, but the false detections were much, much lower. 4.6 and 3.3 false detections per 24-hour period, much more reasonable. And the time to detect a first seizure was quite a bit longer, 29 minutes from the first seizure to when the algorithm picked it up as a median. And for Persyst, where we've actually analyzed all of our cohorts, for patients with seizures, it identified 95% of those babies with seizures correctly. There was, again, 3 with seizures that were missed. It also had false detections in 91% of the children without seizures. However, those false detections were again quite a bit lower than our previous generation at 3.6 and 2.3 false detections per day. And it picked up 61% of the individual seizures with a time to identify first seizure median of 1 minute. For people who are a little bit more visual learners, this is what that data that we just went through looks like. So this is false detections per day for babies who had seizures versus babies who did not. And we can see that for our previous generation algorithm, we can see why the messaging system would get turned off. This is a lot of false detections, but our new generation detectors looking pretty good. A much more reasonable number. There are a few outliers on both those that have seizures and those that don't, where we're getting a lot of false detections, but the medians are quite low. When we look at that percent of seizures that are identified, you can see, and keeping in mind that when we look at humans compared to each other, generously, they would agree something like 75% of the time. We're starting to get there. BABA identifying up in that range, NSDA quite a bit lower, and Persyst reasonably good, a little lower than probably human-to-human agreement in our cohort. And then we care about how long it takes to pick up that first seizure. And we can see that BABA picks it up quickly, as my family would say, well, a broken clock is right twice a day, so it's not that surprising, given the number of false detections. But NSDA is a little longer, with that 75th percentile bumping up at 100 minutes, so it could be a couple of hours before your first, the algorithm picked up a baby who is seizing. Persyst, much tighter. When we do a little bit more of a deep dive specifically into the Persyst algorithm, these are violin plots that let us look at the distribution of performance based in babies with seizures and babies without, looking at false detections. And we can see that the majority of our false detections are quite low. This is where a median of less than 5 is coming. There's certainly a reasonable number that are going to have false detections up to 20 per day, and a very few who are way up there. And that distribution is even more bottom heavy in babies without seizures. I thought this one was particularly interesting. This is looking at the percent of seizures that are correctly identified. And when we look at this distribution, we can see that there are certainly plenty of babies where algorithm and human agree 100% of the time, or something that is, similarly high, 80, 90%. Is this relatively even distribution where there's a similar number where the algorithm and the human agree 75%, 50%, even 25%, and a few even where they don't agree at all. So this very broad distribution of agreement across the entire scale. And then lastly, when we look at that time to first seizure, we can see that we have quite a bit that I agree either exactly at 0 or right around it. But we do have this very long tail where there's a few babies that are being identified quite a bit after they initially started seizing. So I would say overall, this data makes me really hopeful that our new machine learning algorithms are improving. I think there's a lot of questions that are left around how we best use that in various different clinical scenarios. How do we deal with some of those edge cases where seizures are missed or seizures are very delayed in identification by our algorithms? How do we not rely on them too much, but enough to be helpful? But I'm hopeful based on this data. So lastly, we're going to touch a little bit on QEEG for background evaluation and some of the promising new data in this realm too. So we know that even though what we use neonatal EEG the most for is to identify seizures, we know the background is also really helpful for prognosis, but we don't use it for clinical prognosis all that often. We've known that for a long time. This is back from 2010 as we were starting to implement therapeutic hypothermia as our standard of care across the world. And this is looking at time to return of sleep-wake cycling, both in children who did and did not undergo therapeutic hypothermia, where children who had a good neurodevelopmental outcome, broadly defined, are these open markers, and those that had disability were in the closed markers, and those that died are stars. And we can see that those who had a return of sleep-wake cycling relatively quickly over the course of cooling, typically did much better than those that either had a later return of sleep-wake cycling or never had return of sleep-wake cycling. And more recently, this is a beautiful study from Glass et al. In 2023, where they looked at the HEAL babies and they manually graded the background as on a range from predominantly normal to predominantly discontinuous to predominantly severely abnormal, and then looked at neurodevelopmental outcomes. And we can see that you have this lovely stair step where if you have a mostly normal background, your odds of having no neurodevelopmental impairment are very solid. Up through if you have a predominantly severely abnormal background, those babies died. And all the mix in between. So we know that EEG background is strongly associated with neurodevelopmental outcomes in infants with neonatal encephalopathy. But we also know that it is challenging to get a consistent manual a grading of that background. Now, it's one of the main barriers to using this prognostically. And so I wanted to highlight a really neat new research algorithm out of the BABA lab in Finland, where they took background and they used machine learning to develop this BSN, is the quantification of background. And at any given time, it grades the baby's EEG background and gives a number between 0 and 100. And so this is looking at the correlation between the number, the grading, BSN grading, and manual grading of background into inactive, burst suppression, continuous without sleep-wake cycling, and with sleep-wake cycling. And we can see that while there's some overlap in this distribution, it really correlates quite nicely. And perhaps even more importantly, when we look at some broad categories of outcome, we look at those that have a favorable outcome versus those that have cerebral palsy and epilepsy, or those who died. We can see there's distinctly different trends in grades, where there are a few children with favorable outcomes who initially had a very poor background, but they improved over time, which I think probably fits with what we all see when we're looking at neonatal EEGs of the kiddos who do well versus kiddos who died or had a poor background tended to have much less improvement. And when we look at the distribution at 6, 12, 24, 36, 48, and 72 hours of the children who did well in green versus those who had cerebral palsy, those who had cerebral palsy and epilepsy, and those who died, we can see that while there's certainly overlap, there's distinctly different grades, quantified grades in background between these. Now, this is still very much a research application that is not ready for clinical prime time. But for me, this gives me a lot of hope that we're going to be able to create a quantified measure of background that we can incorporate into our prognostic discussions with families and be able to give them some clearer answers than we can currently give by incorporating that with everything else we know about the baby. It was something that I would certainly enjoy, given that these are discussions I have all of the time, and these are families that would really love to have as much information as we can give them about what the future may hold. So overall, the things that we've talked about today is we reviewed some trends that we currently use in the neonatal ICU. We looked at quantitative EEG for seizure detection and some new data that makes me hopeful that new machine learning algorithms are improving to the point that we really can start incorporating them into clinical use. And we looked at quantitative EEG for background evaluation, and that there are some promising new tools on the horizon for improving our ability to support prognostic discussions in these babies. And with that, I would love to take questions.
Thank you, Dr. Keene. What a great talk. As we wait for the questions to roll in, I have a couple for you myself. The last piece that you showed on the background EEG of the baby and how it correlates to their prognosis, use that information in discussions with families about the prognosis for the baby. I was also wondering if there's, at this point in time, if there's any way that clinical decision-making would change based on that information, or is it only useful in discussions of prognosis?
I think some of it depends on resources, because we certainly are looking at how do we best use our resources to support the kids who are at risk for neurodevelopmental delays. And in an ideal world, every child has access to trained therapists, developmental specialists who are watching them like a hawk and giving them all the support we can, because we know that early developmental support can make a big difference. In the real world, those resources are limited. And so the better we can identify the kids that are really at highest risk and would most benefit from intensive early therapies, I think the better. And so, even if that means we can identify a really low risk, that also is important from a resource distribution, but also for parents, being able to tell parents early on, I make no promises, but gosh darn it, I'm really hopeful your baby is going to do well. That would mean the world to a lot of our parents.
So you're talking about like a lot of behavioral support, like therapists, like speech therapists and cognitive therapists, those kinds of therapists, but not necessarily like a bedside change in care per se.
Pretty rarely would be my guess,
Yeah.
because most of the times where you're going to have a change, it's typically going to be a change around goals of care.
Mhm.
And usually the cases where we're really having a discussion with families where goals of care may change and they may choose not to pursue things like enteral feedings, etc.
Mhm. Got
We
it.
usually have a pretty good idea from other pieces of data. We have, a clinical exam that looks really bad. We have an MRI that looks really bad. Certainly, and EEG data supports that, but by itself, those edge cases are probably the ones where it's less useful because we can look at that EEG and go, yeah, the EEG looks bad, MRI looks bad, baby looks bad. We can be pretty
Mhm.
but I think some of those ones in the middle are where having that quantified number may help us fine tune our prognosis and our developmental supports more.
Yeah, yeah, it makes sense. I really like the research software that you showed that's quantifying the background for you and giving a grade. We know that background is really important across many clinical indications, cardiology, all these different areas of medicine. So of course it makes sense that it's going to be important for neonatals as well. Um, so for the discussion on false positives, it all does look pretty great in terms of making progress from the early models now to what we have in terms of the current models. And your graphs all look really good, but my I'm stuck on the false positives in the babies that aren't having seizures at all. And so, it was pretty high in both of the newer types of the detection algorithms. What are your thoughts on that? I mean, if you're having babies that aren't having seizures and the software is telling you that they are you going to turn it off in real life? I mean, it's great for the other babies, but what's your sort of practical use opinion on the false positives for the babies that are not actually having seizures?
I think even the babies who aren't having seizures are false positives. Medians are in that 3 to 4 per day, which is a lot more doable than the 60 to 80 per day that we're seeing in the previous. 60 to 80 is enough that you just turn it off. It's
Yeah.
not helpful to you. 3 to 4 is probably low enough that it means that you don't want to use it without secondary review, right? I would
Mm-hmm.
want to just put it at bedside and say, if the algorithm says the baby is seizing, give them phenobarb.
Mm-hmm.
But is it useful in a use case where it's alerting your techs to look at it? And then your techs are probably able to screen out, half of those and say, oh no, I see padding or I see other things where I can identify what that error is. And then
Mm-hmm.
2 a day, the epileptologist gets a call to say, I'm not sure if this is a seizure or not, confirm or not. And
Mm-hmm.
they say, no, I don't think it really is. That's doable. Like 1 page every 12 hours, that's doable. So I think we're getting down to the point where that's useful in specific use cases, right? And so I think that's where a lot of the work is going to be is how do we use it? How do we identify the places where we can use it the best?
Right, exactly. And that actually was another question that I had for you across all these different environments. Um, what are your thoughts on how this will change care and what are the challenges in terms of uptake of this kind of technology?
I think one of the big challenges in uptake is that data that we looked at that humans don't agree with each other, right?
Right.
And so if you and your, dear colleague that you think is a great EEG reader are sitting next to each other and reading the same EEG, you're going to agree 75 to 80% of the time. But you never do that. And so you never get that person-to-person comparison, which means that as you're, but you are going to get that with Persyst. So no matter what, you're going to go through, you're going to 20% of the time, you're going to be like, ugh, that's a crap call. That, that's definitely not a seizure. Or
Right.
of
Yeah.
course that's a seizure. So even if it had exactly the same performance as your colleague, 20% of the time you're going to be like, ugh, it's wrong.
Yeah.
Like
So then you feel like it's not
um,
very good, even though you would disagree with your colleague the same amount.
exactly.
Yeah.
So I think that's a big challenge for uptake of, for epileptologists to
Mhm.
embrace it. That said, one of the projects we're thinking about is working with our techs, because a lot of our techs are scared of neonatal EEG.
Mm.
They're hard,
Mhm.
and they're intimidating. And so, I don't think they would have the same challenges with being certain that they were right that some of our epileptologists do. And so I think that's a case where they would love to have a second, essentially expert sitting next to them that they could say, oh, it thinks it's a seizure. I kind of think it's a seizure. That's probably enough for me to escalate it to the expert to take a peek at it.
Mhm.
And so I think that's a case where it would be really useful. I think in cases where you don't have techs available, and
Yeah.
this is epileptologists who are typically looking at an EEG once every 12 hours, which is certainly a case in many settings.
Mhm.
Having something that was available and flagging things in between, that could alert you to seizures much earlier. That's
Mhm.
one where it really depends on that the false positive frequency, right? Because
Yeah.
70 times a day, you're going to ignore it. And the answer is they get what they get on a Q12-hour read. But if it's 2 times a day that it's saying, hey, take a peek at me a little bit earlier, that becomes much more doable.
Right.
Cases where, if it was again, I think I would have a hard time with implementing without access to any expert to be able to read over it. That's not what I would want for my baby, but I'm also probably a little biased. Um,
Yeah, for sure. I think your point about the technologist perhaps being able to use it to support their own review of the EEG and helping them know when to escalate or not escalate. I think we typically have a lot of technologists in our audience here for Persist Grand Rounds. So I'm wondering if there's any of you that are listening now that would be willing to chime in on your experience and whether or not something like this would feel supportive to you in your review of neonatal EEG. Um, and so, yeah, we're still waiting for folks to chime in with questions. So any comments? I see someone's hand is raised. If you have a question, you can type it in the Q&A or the chat, and I will pick it up. Okay. And so then another question for you while we're waiting is, how did you decide on which algorithms to use in your study? I mean, there's got to be more out there than just the three that you
yeah.
parameters were you looking for?
Well, the three that I chose were ones that are coming from labs that have, or companies that have a long-standing history in quantitative EEG,
Okay.
um, from people who are well-known in the field and that have algorithms that are available and were interested in working with us to test them. So there's also a pragmatic component of getting systems to talk to each other.
Sure. Yeah, that makes sense. But also it makes sense that you would choose algorithms that have a long history of work in this area. Um, okay, interesting. And we do have a request to see the BSN graph again.
Yeah.
Great. So maybe there's a question related to this slide. I love this slide. It's beautiful. Oh, chat apparently is disabled. Great. Well,
Oh.
the Q&A is working. Okay, so some feedback is that someone weighed in and said that they would find the algorithm useful as a tech, like an extra pair of eyes. Exactly. And I think, the challenge is getting people to think about it that way. Dr. Keene, your point is completely on point where most of the time you don't sit side by side with a colleague and argue over what you think is a seizure or not a seizure, but with Persyst you will.
Yeah.
And so the perception is that it's, it's wrong a lot. And and so getting people to see the value of it, even though there are times when you disagree with it, is the challenge, I think. So it's an issue, perhaps of perception. Um, and so, in terms of the abilities of the algorithms themselves, very interesting to hear you discuss how the early ones were really based on feature recognition. And then as we move forward into the more recent kinds of algorithms, they're based on the raw EEG signal. Um, where do you see this developing from here in your perfect world? Where should the future go, and what are you looking for in terms of a clinician and your ability to care for these babies?
I think, we are still early days in some of these new algorithms that are really using that raw EEG signal. And what we've looked at and what is probably most easily looked at is one category, our neonatal encephalopathy babies. They're a relatively cohesive and defined group, but we know that preterm EEG at baseline is really, really different from term EEG. And my suspicion is that if I
Mm-hmm.
asked any of these algorithms to identify seizures in the preterm babies, they would struggle very
Mm,
hard. And even that's probably true in some of other populations. It's a little, our CICU post-operative babies, their baseline is really different because they're very discontinuous and on a ton of drugs. I'm not sure how it would perform for that group.
mm,
So I
mm.
think there are a lot of, a lot of work that needs to be done to make this more broadly applicable, as well as understanding what settings that this technology would be most useful for.
Yeah, that's a great point. I mean, any algorithm is only as good as the data that it was used to train it. And so to your point, there's a lot of different types of babies that have different backgrounds, different baselines going on in their EEG. And to your point, preterm is different from term, which is different from the babies in the CICU. So one challenge then that you're pointing at is to be able to get data from these populations that could then be used to further train the algorithm so that it can handle data from these populations. Yeah, definitely that's a challenge. I imagine there's a lot of practical challenges and then obviously the quantitative and training challenges as well. Um, yeah, that's interesting. And your study, maybe I missed it, your study here of the data that you're showing, it was done on what age of neonates?
All term. So
Oh,
these are kids
okay.
that were candidates for therapeutic hypothermia, so greater than 36 weeks.
Okay. Do you
So
have plans to test it on other age, like preterm, for example? Or
yes, if we can get access to a sufficiently large database. I think any of our
yeah,
individual centers, there's a much smaller population of those preterm babies that we
yeah,
typically are wondering. Because even though we think the seizures are probably pretty frequent in that population, they are even more unlikely to have clinical manifestations of those
right.
seizures. And so we just don't think to put on EEGs most of the time. They're also living in our NICU for a very long time. So identifying that time period, maybe right after they had a brain bleed where they're the highest risk for seizures,
Yeah.
again, we probably miss that time period most of the time. So I think we'll need something, and there are some collaboratives that are coming together, like Dr. Benedetti and Dr. Press are putting together to really pull data from a whole bunch of our centers to be able to do better pediatric and neonatal quantitative analysis on groups like this. And I think that will be really key to being able to generalize some of this newer technology across lots of different groups that are uncommon, like our CIC babies and our preterm babies.
Awesome. That's very hopeful. I love hearing that there's a effort to collect data from multiple centers so that you
Yeah.
can, yeah, ask these important questions. Great. Thank you so much. Before we wrap up for today, I just wanted to ask you, is there anything that you wanted to say or that you wanted to touch on that perhaps wasn't included that you want to share with our community?
Not specifically. I think I'm I'm hopeful about what the future will bring. I think we are getting to the threshold of really being able to use this in clinically meaningful ways that are going to improve the care of kiddos. So I'm excited to see what the future brings.
Fantastic. And I am as well. Thank you so much again for your time. This was a fantastic talk, very useful. I really appreciate your time.
Thank you very much for having me.
Of course, anytime. All right. And with that, thank you, Dr. Keene, and we will say goodbye. Bye, everybody.